I will talk about the interventional options in failing Fontan. And, you know, the Fontan modification is a palliation on time. And if you look at these two examples on the left-hand side, you see an optimally functioning Fontan modification without any problems, without any comorbidities. And on the right-hand side, there is a typical example of a failing Fontan with a very diminished forward flow and causing comorbidities and significant problems. If you look at the long-term follow-up of these Fontan modifications, then some fact is real. Over time, that vascular system will fail. This is a study what we performed in Berlin, and you see all these 63 patients have been followed with MRI investigation, and you see that over time after Fontan completion, the cardiac index, which is on the y-axis, is reduced over time. So that is due to the fact of the imbalance of the driving forces, which is a measure of left atrial filling pressures, which means stiffness and the function of the single ventricle, the pumping part, and the pulmonary vascular system, which is causing pulmonary vascular resistance and elevated pulmonary artery pressure. So if you look at the pathophysiology of the long-term morbidity, especially in these Fontan modifications, you have two parts, which are the two commandments in this situation. One is the cardiac failure, which may be caused by reduced ventricular function, AV valve regurgitations, or a recurrent arrhythmia. And the other part is reduced transpulmonary flow volume, which may be caused by any hindrance in the Fontan pathways or any increased pulmonary vascular resistance due to every cause of that, which is the fact for this, and to intrapulmonary shunts and specifically collaterals as well. So if you look at the clinical signs of these long-term morbidity, you see the patients probably with a protein-losing enteropathy, ascites, cyanosis, arrhythmia, thrombus formations, any complications due to thrombotic events, reduced cardiopulmonary exercise capacities, multi-organ failure, and of course necessity of re-interventions. But in any way, we are in a real dilemma if we are going to deal interventionally with these patients, because there are absolutely no real guidelines available. And it's mandatory to have a specific risk stratification, which is with regard to the myocardial function, to the pulmonary vascular resistance, and to all of these concomitant diseases like liver dysfunction or renal dysfunction. The interventional treatment should in any way improve not only the quality of lives, but should avoid all surgical steps and should reduce morbidity and mortality in any way. But so far, there is no real established standard, and so far there is no real evidence for this interventional treatment. So it is individual decision-making in really every case. So our goals are the optimization of the Fontan circuits. And every approach what is going to be performed should result in an improvement of the cardiac output in these patients. But the risk stratification, whether the surgery probably bears the lower risk of your approach, is mandatory. For example, whether a conversion of a intracardiac Fontan modification to an extracardiac would bear the lower risk, that would be the preferable procedure. In any way, it is multimodular, which means interventional steps, medication, EP studies, and pacemaker implantations. And at the very end, there are secondary fenestrations and takedowns, which are also being manageable with interventional techniques. And I will come back to that later on. Ahmed demonstrated these interventional options. These are not only the closures, these are balloon dilatations, recanalization of thrombosed vessels, closures of collaterals, of fistulas, residual surgical shunts, residual outflow tracts, stenosis, compressions of pulmonary veins, and as well at the very end, the very important the point of ablation of any concomitant tachyarrhythmias. So let me show you some examples. This is 6.5 years after a total cardiopulmonary connection, and you see there that is a a severe stenosis at the part coming from the IVC. That is awful, sorry. I will take my mouse, which is sometimes easier. At this part, and later on you see after implantation of a stent in that part, which get rid of the stenosis and rid of the gradient, you saw that there was an intrahepatic venous collateral formed with a connection to the left atrium, which also causes a problem and could be managed with implantation of a atrial septal occluder in that connection to improve the forward flow to this Fontan modification to the pulmonary arteries. So some of those are suffering from pulmonary arteriovenous fistula connections. Most of them are diffuse and not really manageable by interventional techniques, but if these are in this manner and combination, then you could put in coils, occluders, or something else to get rid of these malformations, which is improving the saturation in this patient from 80% to 94%, which is enormously sufficient in improving the quality of life in these patients. Some of those are developing very, very strange paravertebral veno-venous collaterals. And these are extremely hard to access for closure, but they can have an extreme amount of cyanosis which they are going to cause. And for this reason, it is very important to get a specific access to these. This is a CT-guided access coming from the back beside the vertebra, with a CT-guided puncture, as you can see here, from the back to the venous collateral, having access to this huge venous malformation and putting in an occluder type here, which is not only closing the entrance to the left atrial cavity, but also from the access to the venous collaterals to have a total occlusion in these patients, as you can see here. This is injection in the access part, which means that only the left atrial is filled, but no any residual connection to the venous collaterals are obvious anymore. Another very atypical paravertebral venous collaterals, which is very often the case in especially adult patients with long comorbidity and severe cyanosis, as you can see here, is a very tortuous course of the catheter coming from the aorta retrograde, coming into the single ventricle, going back to the left atrium, and then entering these collaterals. And there it is no way on the retrograde course to have any closure. So that was the reason why we punctured it with a radio frequency guided puncture system from the SVC towards that cavity of the venous collateral to have access to that from the upper limb, and implanted a occluder system there, and then we could withdraw the puncture site without any problem, and having resulting in a total occlusion of this collateral flow. So some of those, as Ahmed pointed out, have residual connections to the pulmonary artery side. We know this is in an adult patient prior to a off-bypass Fontan completion, which is very helpful in this situation, having any ventricular to pulmonary connections with establishing some residual flow during the operation. As you can see here, this is the injection, the SVC. Here is the residual pulmonary artery and the connecting to the ventricle. And after completion, we have this patient with problems of thromboembolic events. And you see that that is not only the pulmonary artery connected to the ventricle, but also the total banding of the surgeons during the establishing of the pulmonary connection to the veins. And that was the reason why we had to close these. The first closure was the connection to the ventricle, and the second closure was implanted in the subtotal banding so that we excluded this blind sac from the pulmonary artery towards the modification. With regard to the thromboembolic complications, this is not a trivial fact. Especially in adults, you have an incidence of up to 25%, and overall, if you include the kids, you have an incidence of 15% during a follow-up of 15 years. And the post-event mortality, if one thromboembolic event happened, the post-event mortality is nearly 40% in the patients. Intracardiac thrombosis are a bit more rare, but it is a traumatic problem in any way. And here is a patient, what you can see here, who developed a total thrombotic occlusion, a pulmonary embolism of the whole left lung, and came in a very severe clinical situation to the clinic. Here you see the thrombotic formations within the whole pulmonary stump here, and could be vacuum embolectomy with a large sheath and a thrombolysis followed by low molecular heparin, coumadin, and aspirin. But in this situation, it was very important to exclude the remaining pulmonary stump, which has been established with a occluder implantation at the part to the remaining sac of the pulmonary artery. Some of the adult patients suffers from a problem of a Björk-Fontan circulation, which is most often a matter of the implanted valve. And here, as you can see, the measurement of that, which is 25, 26, 28 millimeter in diameter. That is something in the earlier days where we didn't have access to the Edwards valve, so we should use a specific modification which has been published by Peter, which is a custom-made reducer, a covered stent with a mega LD EV3 at the outside, and then with inflation of the balloon you have a restriction in the middle which gives you the bed for implantation of also the melody valve, as you can see here. This is the inflation of the modified reducer here in the implanted homograft, and there is a severe stenosis or a right stenosis in the middle where we can implant the valve, and after inflation of the valve here, as you can see here, which nicely works without any problem, even though being a 22 millimeter delivery system in a measure of 26 originally, which is easily to implant there with a absolutely nice functioning system afterwards without any real problem. If you look at the very end at the really failing circulation, there are some techniques described to open up the fenestration. This is Oliver Stümper, and with a Stümper technique with a Diavolo stent formation, which is created by a pacemaker lead with a recent and a significant measure of the diameter what you want to achieve. And this was modified from Marco Willig in Belgium, where he supported this type of the Stümper technique with a specific implantation procedure with development of part of the stents in the left atrium and then withdrawal of the sheath to establish the Diavolo stent formation. The problem with this is, especially if you have extracardiac Fontan with Gore-Tex, is to have access to the remaining atrial part, and this is sometimes what is very hard to achieve. And in this situation, it is helpful to have a specific modification of the puncture technique. We have a snare around the puncture catheter to have a better stability for puncture and to avoid any displacement of the needle while we are pushing very hard to get through the atrium. And that is very easy if you have a very sharp needle which is specifically designed to cross these structures, but it is not really an easy case, and you need hard pressure to push to get through, and then you can dilate it up as we described it here with the Diavolo stent in this situation. So there is some how a need of a takedown, of the necessity of a takedown in these patients. And I'd like to demonstrate you the hybrid approach of a takedown. This is a failing Fontan circulation in a 8-year-old boy. And you see here is a communication of the, here's the connection to the pulmonary arteries, and you see the very diminished forward flow in this situation. What we first did, we established the fenestration to the atrial part, as I described you, and afterwards we asked the surgeon with a mini sternotomy to have a ligation of the upper part of this tunnel, which he already did. And afterwards, as that is what you can see here, and afterwards we had to create a large connection, which we did with high pressure balloons to end up in a 16 millimeter connection to the atrium, and that was a takedown without the need of the cardiopulmonary bypass in this situation. So at the very end, we had a takedown of the shunt, as you can see here, of the Fontan. If you look at the complications, and as I pointed out, there is no real intervention standard, and there are no guidelines to how to proceed in these patients. It's always an individual decision-making for any individual patient. All imaginable complications are really possible, but due to the experience of interventions in Fontan circulations, the complications rate seems so far very low, and but only a systematic and comparative randomized trial would prove interventional treatment to be the right and the preferable approach if that is possible. But very important is to have in mind that if the risk for complications exceeds the surgical procedural risk, interventional treatment seems to be contraindicated. So let me conclude. Interventional treatment may be very sufficient to optimize the Fontan circuit, especially also in the failing Fontan circulations. If it requires an enormous intervention of armamentarium, and it requires very flexible thinking, flexible decision making, especially if you need to access atypical positions which are normally not to be accessed by or via the right and the standard way. The interventional treatment seems to be of a calculable very low risk, and in patients with low PA pressures, the re-establishment of the non-obstructive flow may lead to complete disappearance of chronic ascites. So far, the Fontan circuit remains very complex in any way, and it requires multimodal judgment and treatment to improve quality of life and long-term outcome, which also includes the medication and the taking care for the arrhythmia problem. Thank you very much for your attention.